Good morning. I would like to thank Professor Francesco Cognetti and my friend Alessandra Fabi. It's a very pleasure to introduce Professor McKenzie from Canada. He has emphasized the physical well-being of breast cancer patients. And here there are the Dragon Boat Italy women, and the Professor McKenzie will talk about physical exercise and breast cancer risk correlation to subtype and the therapeutic effect. Thank you, Professor.
Well, thank you very much. And I'd like to thank the organizing committee for inviting me to come to one of the world's great cities. And it's always nice to spend some time. And it's also nice to see some of my friends in the front row. So this is, let me see if this will move. Yeah. It looks like I have around 20 minutes to try to convince you that exercise should be standard of care. And I feel very strongly about that. So I'd like to start firstly by explaining where the ladies in the front row originated, how this all came to play. Now, I am not an oncologist. I'm a sports medicine physician. I have a PhD in exercise physiology. And about 15 years ago, a patient was referred to our clinic at the university with a sore shoulder. And the woman came, she's of late 40s, with a painful shoulder, and I examined her, and she had a fairly simple problem, rotator cuff problem, that's easily fixed with exercise. And so I said to her, here is a group of resistance exercises for you to do, and that will fix your shoulder. And she said to me, no, I told you I have breast cancer. I can't do those exercises. And I'm naive, so I said, no, they're not hard, but you can do them. You'll get better. And she said, no, if I do those exercises, I will get lymphedema. So that was a bit of a puzzle to me. So I went and I looked up, and this is in 1995. These were the patient guidelines in Vancouver, British Columbia, fairly standard actually. And these are the things that the patients were told that they should not do for fear of developing lymphedema. Heavy lifting, vigorous repetitive movements, rubbing, scrubbing, etc. Do not use the driver to golf, probably not a bad idea maybe. No water skiing, and finally no canoeing. So canoeing has been a significant part of my life. I've been to 10 Olympic Games, and I'm still on the IOC Medical Commission for canoeing. It's a good sport, and so I think everybody can canoe. And so we decided we'd start a team of women to challenge the myth that exercise does not cause lymphedema. And so this is in Vancouver. Yeah. So this is in 1995, actually the spring of 1996, and these are very, very, very important women, 24 of them, because they are sticking their neck out a great deal. They are going to do exactly what the medical profession has told them not to do. So they're going to challenge the issue of lymphedema. So they don't know anything about dragon boat paddling, and so people will often say, well, why did you pick dragon boat paddling? And as a canoeist, it's the entry form to the sport. This is a very stable boat. It's a safe sport. But when you look at it, these women are going to do strenuous, repetitive upper body activity, exactly what's supposed to cause lymphedema. It's aesthetically pleasing for any of you who ever go on the water. And you can get 22 to 24, sometimes in some of the bigger boats, 26 people in the boat, which is important because when we push off from the dock, they can't get out, right? So you have a captive audience for whatever you're going to do. It's non-weight bearing, which is important. The women on average, this group was 55 years old. And you can get a very powerful training stimulus. As an exercise physiologist, I can put a 27-year-old woman in the front seat beside a 72-year-old woman, and they can paddle together. The absolute amount of work is different, but the relative amount is the same. And it's quite simple to do that. They get quite a good training stimulus, as I'm going to show you. And I say it connects you to the environment, which in Vancouver means you get to paddle in the rain. So the program said, though, before you can get into the dragon boat, you have to do 2 to 3 months of work in a gym. This is in 1995, 1996. You did not see 55-year-old women in gyms, at least in North America, at that period of time. The exercise program was very simple. It involved some aerobic capacity, walking, jogging, rowing, etc. It involved some strength training. Balance is always good for people at my age, and also some flexibility. And so they were novices, and they came to the gym, and we supervised exercise programs for them before they got to get into the boat. Now, we have a lot of data. I have a pretty nice laboratory at the University of British Columbia, and we collected a lot of data on the dragon boat paddlers. And we measured aerobic capacities, we measured anaerobic capacities, we could measure strength. The first year, we did lymphedema assessments on every member before and after every practice. And then we also looked at issues, mental health, quality of life. But we do have a lot of data on that. We got interested in the whole issue of lymphedema. As a physiologist, it didn't make sense that you could challenge the lymphatic system and it would fail on you. So we actually developed what we call a lymphatic stress test, which is the same as a cardiac stress test, except it involves technetium labeled antimony colloid, and some exercise, and you can follow what happens to the lymphatic system. Now, we did all this. No one in the first year got lymphedema. A lot of people improved range of motion. Everybody had a smile on their face. This was a lot of fun. They went to a big dragon boat festival in Vancouver 6 months after they started. That was really, very positive experience. And so we can say at that point in time, if you do dragon boating, you get really positive effects, functional improvement, physiological, psychological benefits, no lymphedema. Now, I thought after 6 months, these women were going to go away because the study was over, and we had proven that lymphedema was not caused by exercise. But that didn't happen. And the next year in Vancouver, we had 2 teams, and one in Victoria and one in Montreal. And the next year, there were some in New Zealand and Australia. And this has evolved and continued to evolve, and we're now in our 22nd year. And this is a picture from 2 years ago. This is a drone shot. This is Sarasota, Florida, new rowing course. And every person in pink on that photo is a breast cancer survivor. So all of these women have come from all over the world to participate in a dragon boat regatta. And the point about this is we call them participatory regattas. And it's a participatory regatta because if you have gone through the process of having breast cancer, all we would like you to do is to get you to the start line. Because when you get to the start line, you're already a winner. So we've had participatory regattas. We started them in Vancouver 10 years after we started the whole program. And as you can see, we've had them in Australia, Eastern Canada, Florida. But what's most important is our next participatory regatta is in Florence, Italy, in July of next year. These are important things because it brings together the breast cancer people from all over the world. There will be 3,000 or so athletes there. And the nice thing about breast cancer for women who are in their late 40s, 50s, 60s, 70s is that their family comes with them. It's payback time. For all the hours they've spent watching their children in the soccer field and doing what have you, now they will come and follow them and watch their mother, sister, whatever, participate. We will get 40,000 spectators. We'll have workshops developed to show compression sleeves and new interventions in terms of exercise. It's usually very well sponsored. It's a significant impact to the host city. And the actual bidding process that they do in order to be able to run this regatta is actually not unlike the bidding process for the International Olympic Committee that I sit on. So it's actually a very, very, very well organized, structured group of people. Oh, come on. Oh, there we go. So as I say, it's moved on. This is an old slide, but really we have teams in at least, well, there's quite a few more than 200 cities now across 6 continents. And here the pink butterfly, this is from an old photo, I think, from quite a few years ago. But as a clinician, I learned more about breast cancer from these ladies than I ever did in medical school. And sitting in the boat or steering is what I often do. You know, the information that you get from the patient is very good. And we heard about that earlier today in terms of being, you know, a positive psychological, cultural experience. Italy now, this is a dated slide too. There are 14 teams in Italy. And the nice thing about the teams in Italy is they all volunteer to be subjects in research. If you're looking for some research subjects of physically active, highly energied, positive women, there's a group in front of you right now. And there's publications, quite a few good publications that have used dragon boat paddlers looking at the effect of exercise in a cancer population. And it's not just quality of life. It's things like metalloproteinases and chemical markers, longitudinal strain, affecting the heart function after anthracyclines, etc. So they're you know, extraordinarily wonderful people to volunteer for these things. There's a trickle-down effect, and so in Vancouver now, we have a pediatric oncology group. My daughter and I train, Strength Within, a group of CNS kids from Children's Hospital, brain tumors. They come and they paddle, they exercise. The nephrologists have a team called O2P. The multiple sclerosis team, off balance, visually impaired, eye of the dragon. We actually have a solid organ team, transplant team, and there are patients that have had, with cystic fibrosis, that have had double lung transplants that are getting into dragon boats and exercising. Now, I'll go back a step. This is a problem we have in North America. We now have this sedentary activity, and breast cancer patients, when they develop breast cancer, the cancer disease process does make them a bit more sedentary. And this is old data, but I don't think it's changed much. And this just shows what happens before the diagnosis. This is all activity, recreational, household activities, work activities. And you can see what happens on the basis of staging. It's pretty independent of age. Your amount of exercise that you do or physical activity decreases independent of what age group you're in. It does change a bit in treatment, and on the far right, you'll find that the changes are more significant when you put chemotherapy into the mix. And so looking at exercise and breast cancer, exercise becomes more of an important feature because we don't want the effects of cancer and treatment of cancer to influence the level of physical activity. We've done a fair amount of research in our lab, and there's lots of research going on. It's all exercise related though. Supervised trial of aerobic and resistance training was 10 and 12 years ago. We have longitudinal data on these patients. We have another study called CARE, which again, we've published all of this in Journal of Clinical Oncology and other places. If you punch exercise and breast cancer into PubMed, you get 3,000 publications. And you can read them all, but they all come down to this. Physical activity in the cancer patient, breast cancer patient, uniformly increases the capacity of your energy system. Your heart and lung fitness goes up. You get stronger, your muscular endurance increases. Your flexibility will improve sometimes, more so if you add yoga, etc. into this. You will develop changes in your body composition and also bone density. We published a paper not too long ago showing reversal of sarcopenia and changes in bone density simply on the basis of exercise. The positive thing that we see, probably the most positive thing we see with exercise, is change in the psychology of the patient. When you are a breast cancer patient, as you know, you have two things that you have control over. You have diet and you have exercise. And so when the people choose diet or exercise, it seems to have a positive effect. It also seems to have positive clinical effects, and this is where the exercise people need your help. In Vancouver, if you're a cancer patient and you come to the oncologist for the first time, this is the thing that is on the front of your chart. And this basically asks the patient, requests the patient, in fact, encourages strongly for the patient who's just going to start chemotherapy to participate in a supervised exercise and nutrition program. All they have to do is check the box at the top. Near the bottom, they check off comorbidities. Some people may have COPD, type 2 diabetes, arthritis. Give us a list of the drugs that they're taking, sign it, and that gets the entry level to the cancer gym. So we have a facility, we have 2 now in Vancouver, and we do some preliminary evaluations with fitness levels and DEXA scans and what have you. And then you're involved in a supervised program at our gym. And this, one of the oncologists in Vancouver and I set this up about 15 years ago. As you can see, it's a pretty regular looking gym. It's only for breast cancer patients. It's quite nice. And here's a group of women from the cancer gym. This, if you're a clinician, will be helpful to you to have women in this position. And the reason for that is when you develop cancer and you come to the cancer gym, you come in at one at a time. And when you first come to the gym, you walk in, and this is the group that says hello to you. Very positive, organized women. And so you walk into the gym and you're terrified because you're going to have chemotherapy next week. But one of these women will come over and introduce herself to you and say, and give you pearls of wisdom. Make sure you take the medication when the doctor told you before you get the chemotherapy. Okay. A week or 2 or 3 or 4 weeks later, when your hair starts to come out, a couple of women will take you down to the place where you can get a wig. If you have a problem with lymphedema, they'll talk to you about where to go to have a compression sleeve and get it treated. This is not just a support group, it's a resource group for patient management. And the oncologists that work with our group here find that this is one of the most important and supportive groups that we can have within the gym itself. How about side effects? Well, on the left-hand side, you can see the ones that you're familiar with. Exercise, by and large, is safe. The most common thing that we see in people who come to the gym is the fact that they haven't been to the gym before, and they have some muscle soreness and aches and what have you. We've also done some work with aromatase inhibitors and find the same sort of thing. More anecdotally, the people who participate in the gym seem to do better on aromatase inhibitors in terms of side effects. Exercise, however, is a challenge test, and so you have to be cautious when you initiate this, and that's why these are supervised tests, supervised programs, and they're evaluated by the clinicians prior to initiating it. And if people have weak links, exercise will point them out. Now, if I haven't convinced you yet that exercise is standard of care, this is some data from prospective cohort studies related post-diagnosis physical activity. After you're diagnosed with cancer, go and do some exercise. And this is on cancer-specific mortality. And what's interesting is you can see every breast cancer study shows a positive effect of exercise, but it's the same in colorectal, prostate, and in fact the overall risk estimate is pretty impressive, really. This is doing post-diagnosis exercise. And the exercise on that is quite varied. Some people are doing 3 hours, some people are doing 2 hours, some people are doing resistant stuff. It's something that we need to work on. That's for cancer mortality. This is for recurrence. And again, if you exercise, the recurrence rate is improved. Now, and it's improved in every study, and some of the work up there that is from our lab. One thing we're concerned a little about is the variability of this, and that's why, again, I think we need help from the oncologists to help us decipher this a little bit more. The problem with exercise, as I see it, is this. There are guidelines for exercise. World Health Organization has a guideline. A number of cancer societies have a guideline. The American College of Sports Medicine has a guideline based on exercise as medicine, and that seems to be what Italy is adopting in terms of guidelines for exercise. What it basically is 150 minutes of aerobic exercise of some form, and then twice a week going to a facility where you can do some resistance training. That's the exercise and medicine guidelines, but that's generic. Every patient gets the same thing. So that assumes that breast cancer is a genetic and physiologically homogeneous disease, and you certainly know more so than I do that that's not true. So is there any data that can help us out there? Well, there's a study or paper that just came out from Lee Jones, who's a Canadian researcher. And this shows on the top the recurrence, and on the bottom it shows cancer-related death. And this is on a group that really some do some exercise and some do no exercise. So it needs a bit of tweaking before we understand it completely. But one thing you can see is that the patients with the tumor size less than 2 centimeters do a little bit better. The patients that have a well-differentiated tumor seem to do a little bit better, ER positive and HER2 positive as well. So there are some things to do with the clinical pharmacological appearance of the cancer that the exercise people would like to know more about. So I call ourselves exercise oncology, not clinicians. We're the people who want to prescribe exercise. And I think we're a valuable resource because as oncologists, I know that you don't have the ability and time to start prescribing exercise for patients. That's why you need a cancer gym where you can send patients for the type of supervision that we can provide. But we need help defining the exercise prescription. We need to examine the role of genetic and molecular markers in the cancer biology. We know that exercise is good, but for the same exercise prescription, we get a wide variability in patient response, usually positive. But why aren't we a little bit better at this? We can look at interaction between exercise and cancer. This is just an example. Is the weight loss that we see because people are exercising or because part of the treatment for cancer is affecting their appetite? Are the sex hormone decreases that we see with exercise because of exercise or because they're on an aromatase inhibitor? Is the immune function improvements that you get with a moderate amount of regular exercise because of exercise or because of immune therapy? Are these things additive or are they synergistic? We don't know. This is where some of us are heading, and this is where we need some help. The exercise omics. What happens to a number of proteases and genetic markers, whatever, when we actually start to exercise? What will exercise turn on, and what can be interfaced with the cancer biology changes in the tumor itself that might help us prescribe exercise? So we need a new understanding of exercise and cancer biology to lead us to identify the genetic and molecular subgroups of patients who may be helped, particularly helped or harmed, by specific exercise prescriptions. If we can define these subgroups, these people are going to be highly motivated. If we can say, if you do this type of exercise, this is the specific effect on your cancer, that's a better turn on than we'd like you to do a bit of exercise, come and see us. Might also be supported by the governments in socialized countries like Canada. What we would like to be able to do for your patients is this, and we can't do it now. The information we need, we don't have. We need to be able to say what type of exercise. Is it aerobic? Is it anaerobic? Is it cycling? Is it a different type of sport? What's the dose? How often do you get this exercise prescription? When in the course of the disease does it start? Maybe it's already there. And are there things during the course of the disease that need the exercise prescription changed? But this has to be based on data that we get collectively with you on genetic, metabolic, and proteomic data. So that concludes my talk. I'm hoping that what I've tried to do basically is set the stage for physical activity being standard of care. And exercise should be just as important, perhaps not quite as important, as chemotherapy, radiation, and the other types of things. It's a physical side of exercise. It's a supportive environment that it creates. And again, I'd like to thank you for inviting me, but I'd also like to thank the Pink Dragon ladies for coming today and being here as well. Thank you once again.
There are questions? Okay. Umberto.
You never mention alimentation, food. Probably you should mention together with exercise. That's very important, of course. the correlation with and the fact that also alimentation is important. I mean, in these aspects you mentioned.
Okay, yeah.
Okay. Other questions?
I don't understand.
Okay.
Well, I missed the question. I couldn't understand the question, I'm afraid.
The relevance of food quality and everything.
Oh, yes, yes.
Weight and so on.
Yes, of course, yes. And that's in our cancer gym, they have supervised exercise, but they also have visits from the nutritionist. They come and they have 8 visits from the nutritionist over the course of their treatment with chemotherapy. So you're quite correct. Diet and exercise go together, absolutely.
We thank our pink butterfly for their presence and their work with other patients. Thank you. Okay. Now the break for 10 minutes, no?